Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 316 of our pharmacotherapy series, which majors in hypertensive crisis. The first question reads, TWM, a 30-year-old Caucasian man with a history of chronic glomerulonephritis and poorly controlled hypertension, came to the emergency department complaining of early morning occipital headaches during the past week. He has no other complaints. He has not taken any BP medication in a month. Physical examination revealed an afebrile man in no acute distress with a BP of 160 systolic 128 diastolic without orthostasis and a regular pulse of 90 beats per minute. Fundoscopic examination revealed bilateral exudates without hemorrhages or papilledema. The lungs were clear. Cardiac examination was pertinent for cardiomegaly and an S4 gallop. The remainder of the physical workup was normal. Laboratory results include the following values: a hematocrit of 32%, blood urea nitrogen of 40 mg per deciliter, serum creatinine of 2.5 mg per deciliter. The baseline serum creatinine was 1.9 mg per deciliter. Bicarbonate of 18 milliequivalents per liter. Urinalysis reveals 2+ protein, 2+ hemoglobin with 4 to 10 red blood cells per high power field. The electrocardiogram demonstrates normal sinus rhythm with left ventricular hypertrophy. The chest radiograph is unremarkable. TWM's presentation meets criteria for a hypertensive emergency, i.e., diastolic blood pressure above 120 mm of mercury and presence of worsening renal function. IV antihypertensive therapy is required for TWM. TWM was given 20 mg hydralazine IV, and a repeat BP after 1 hour was 150 systolic 100 diastolic. What are the advantages and disadvantages of parenteral hydralazine, and when should it be used to acutely lower BP? Hydralazine is a direct vasodilator that reduces total peripheral resistance through relaxation of the arterial smooth muscle. It is rarely used to treat hypertensive emergencies because its antihypertensive response is less predictable than that of other parenteral agents. Additionally, hydralazine has a prolonged half-life, which can be problematic if too fast correction or hypotension occurs. It is not consistently effective in controlling crises associated with essential hypertension. Regarding the contraindications, hydralazine should not be used in patients with coronary heart disease because the reflex tachycardia causes an increase in myocardial oxygen demand, which may result in the development or worsening of ischemic symptoms. In addition, hydralazine should be avoided in patients with aortic dissection because of its reflex cardiostimulating effect. In contrast, hydralazine can be useful in patients such as TWM, who have chronic renal failure because the reflex increase in cardiac output is accompanied by an increase in organ perfusion. Regarding dosing and administration, parenteral hydralazine should be considered an intermediate treatment between oral agents and more aggressive therapy with such agents as phenyldopa or nitroprusside. It can be given IV or intramuscularly. The onset of action develops slowly over 20 to 40 minutes, thus minimizing the risk of acute hypotension. Parenteral doses are considerably lower than oral doses because of increased bioavailability. The next question reads, are there alternatives to hydralazine for parenteral treatment of hypertensive crisis? We will now look at intravenous enalapril. Enalapril, the active metabolite of the oral prodrug enalapril, is approved by the U.S. Food and Drug Administration for the treatment of hypertension when oral therapy is not feasible. However, enalapril has been used to treat severe hypertension. The initial dose is 0.625 to 1.25 mg IV and can be repeated every 6 hours, if necessary. To minimize the risk of hypotension, the initial doses should not exceed 0.625 mg in patients receiving diuretics or in patients with clinical evidence of hypovolemia. The onset of action is within 15 minutes, but the maximal effect may take several hours. Because only 60% of the patients respond to BP reduction within 30 minutes, it cannot be reliably used to acutely lower pressure in hypertensive emergencies. Although higher initial doses have been successfully used to achieve BP control, some evidence indicates that doses greater than 0.625 mg do not significantly alter the magnitude of enalaprilat's antihypertensive effect. Enalapril is also beneficial in patients with heart failure. Precautions for the use of enalapril are similar to those of captopril. Because of the prolonged time required to achieve an adequate response, limited clinical experience, and variable response rates, especially in African Americans, enalapril cannot be recommended for the routine treatment of patients with hypertensive emergencies. The next question reads, HZC is a 71-year-old Caucasian man undergoing urgent coronary artery bypass graft surgery after a myocardial infarction. HZC has a history of a cerebrovascular accident and chronic kidney disease. His serum creatinine is stable at 1.6 mg per deciliter. 2 hours after surgery, HZC's BP increased from 142 systolic 90 diastolic to 170 systolic 132 diastolic. HZC was administered IV nicardipine postoperatively for BP control. Is nicardipine an appropriate choice for HZC? Let's consider nicardipine. Postoperative hypertension is typically short-lived and is most commonly seen after neurosurgical, head and neck, vascular, and cardiothoracic procedures, as is the case with HZC. Treatment is typically only required for 6 hours postoperatively, and up to 48 hours for some who may have persistent hypertension. Adequate control of BP postoperatively is necessary to minimize the risk of cardiovascular, neurologic, or surgical site complications such as bleeding. When selecting an agent, one should consider therapies with a quick onset and short duration of action as well as established efficacy and safety in the postoperative setting. Nicardipine is a potent cerebral and systemic vasodilator and a useful therapeutic option in the management of severe hypertension. Its onset of action is within 1 to 2 minutes, and its elimination half-life is 40 minutes. Hemodynamic evaluations demonstrated that IV nicardipine significantly decreased mean arterial pressure and systemic vascular resistance and significantly increased cardiac index with little or no change in heart rate. As a dihydropyridine, nicardipine has less negative inotropic activity compared with non-dihydropyridines. Titratable IV nicardipine has been studied extensively for use in controlling postoperative hypertension and hypertensive emergencies. In the treatment of postoperative hypertension, 120 IV nicardipine was administered as an infusion titrated in the following manner: 10 mg per hour for 5 minutes, 12.5 mg per hour for 5 minutes, and 15 mg per hour for 15 minutes, followed by a maintenance infusion of 3 mg per hour thereafter. The mean response time and infusion rate were 11.5 minutes and 12.8 mg per hour, respectively. The most commonly reported adverse effects included hypotension, tachycardia, and nausea and vomiting. In studies of patients receiving nicardipine versus nitroprusside for postoperative hypertension after cardiac endarterectomy and coronary artery bypass grafting, breakthrough BP was controlled more rapidly with nicardipine and required fewer overall dose titrations. In addition, nicardipine was well tolerated and did not lead to an increased risk of complications. Nicardipine is an appropriate choice of therapy for HZC in the postoperative setting because this agent has a rapid onset of action, and provides sustained BP control during the infusion period. It is easily titratable, with a predictable response, and is relatively free of severe adverse effects. Therapy should be titrated to achieve a BP approximately 10% higher than the patient's baseline. In addition to nicardipine, nitroprusside, nitroglycerin, and labetalol are most commonly used to manage postoperative hypertension. Finally, nicardipine may be useful in patients with cerebral insufficiency or peripheral vascular disease. Because of the potential for reflex tachycardia, it should be used with caution in patients with ongoing coronary ischemia. Nicardipine has been proven effective in multiple studies of populations with hypertensive emergencies, and, as a dihydropyridine, has less negative inotropic activity compared with non-dihydropyridines. In contrast, the non-dihydropyridines parenteral verapamil and diltiazem, although clinically effective for prompt lowering of BP, have not been extensively studied in patients with hypertensive emergencies. Clevidipine, a third-generation dihydropyridine, has also been shown to be useful in controlling BP in hypertensive emergencies and in the perioperative setting. The next question reads, what other IV forms of calcium channel blockers are available? Would any of these agents be an appropriate choice of therapy for HZC? Let's look at non-dihydropyridines. IV verapamil, dosed at 5 to 10 mg, produces a significant reduction in BP, which occurs within 15 minutes and persists for 6 to 8 hours. As a cardiovascular drug, it is primarily used as a rate-controlling agent in the treatment of supraventricular tachycardias. IV diltiazem is approved for temporary control of the ventricular rate in atrial fibrillation or atrial flutter and for rapid conversion of paroxysmal supraventricular tachycardia. Parenteral diltiazem has also been used to control hypertension that occurs intraoperatively and postoperatively and in patients with an acute coronary syndrome. However, published experience with the use of IV diltiazem for the treatment of severe hypertension is limited. Atrioventricular nodal conduction abnormalities can occur during administration of IV verapamil or diltiazem. Patients receiving either of these therapies require continuous monitoring by electrocardiogram and frequent BP checks. IV verapamil and diltiazem should be avoided in patients with sick sinus syndrome or advanced degrees of heart block. Until additional information is available, caution should be exercised in using either agent parenterally to lower BP acutely. In addition, use of non-dihydropyridines should be avoided when acutely treating any hypertensive patient with concomitant systolic heart failure owing to their negative inotropic effects. The next question reads, what factors should clinicians consider before recommending the use of clevidipine? Let's look at clevidipine. Clevidipine is another IV dihydropyridine calcium channel blocker with arterial selective vasodilation properties. Clevidipine is quickly metabolized in extravascular tissue and blood by esterases, leading to a short elimination half-life of 1 minute and complete resolution of hemodynamic effects within 10 minutes after the end of a 24-hour continuous infusion. Clevidipine demonstrates a quick onset of action of 1 to 2 minutes. These pharmacokinetic and pharmacodynamic properties make it an attractive agent for managing hypertensive emergencies. Clevidipine demonstrated efficacy in the treatment of hypertension in both preoperative and postoperative cardiac surgery patients. In this setting, therapy was initiated at a rate of 0.4 micrograms per kilogram per minute. Target BP was a reduction of at least 15% from baseline. The dose was titrated every 90 seconds by doubling the dose up to an infusion rate of 3.2 minute, then increasing the dose by 1.5 micrograms per kilogram per minute to a maximum rate of 8 micrograms per kilogram per minute. Clevidipine demonstrated a median time of effectiveness within 6 minutes in greater than 90% of the patients who received the study medication. Clevidipine has been compared with nitroglycerin, nitroprusside, and nicardipine in the management of perioperative hypertension in cardiac surgery patients. Clevidipine was more effective in maintaining patients within a predefined BP target range when compared individually with nitroglycerin and nitroprusside, but this did not translate to differences in clinical outcomes. Clevidipine was equivalent to nicardipine in keeping patients within a pre-specified BP range. The incidence and severity of adverse events were similar among patients who received clevidipine and comparison agents. Based on the limited data, non-dihydropyridines would not be an appropriate choice of therapy for HZC. Additionally, IV verapamil has a long duration of action, which is not an ideal characteristic in the setting of postoperative hypertension. Clevidipine, however, has a rapid onset of action and short duration of action and is effective in controlling BP in the perioperative setting. Clevidipine infusions can induce reflexive tachycardia with an increased heart rate by up to approximately 20 beats per minute. Clevidipine is formulated in a 20% lipid emulsion, so it should be avoided in patients with serum triglycerides greater than 400 mg per deciliter, and any remaining drug should be discarded after 4 hours of use. Clevidipine is contraindicated in patients with allergies to soybeans, soy products, eggs, or egg products. This agent is also contraindicated in those with defective lipid metabolism or acute pancreatitis, if accompanied by hyperlipidemia, and in patients with severe aortic stenosis. The next question reads, KBS, a 68-year-old Caucasian man with a long history of hypertension and non-adherence, presents to the local emergency department complaining of the sudden onset of severe, sharp, diffuse chest pain that radiates to his back between his shoulder blades. Significant findings on physical examination include a pulse of 100 beats per minute, BP of 200 systolic 120 diastolic, clear lungs, and an S4 without murmurs. The laboratory data are unremarkable. The electrocardiogram results are interpreted as sinus tachycardia with left ventricular hypertrophy, but no acute changes are noted. The chest radiograph is significant for widening of the mediastinum. An emergency chest computed tomography scan reveals a dissection at the arch of the aorta. What antihypertensive medication or medications would be most appropriate for KBS, and why? Dissection of the aorta occurs when the innermost layer of the aorta, called the intima, is torn such that blood enters and separates its layers. The ultimate treatment for this type of hypertensive emergency depends on its location and severity. However, the first principle of therapy is to control any existing hypertension with agents that do not increase the force of cardiac contraction or heart rate. This lessens the force that the cardiac impulse transmits to the dissecting aneurysm. The aim of antihypertensive therapy in aortic dissection is to lessen the pulsatile load or aortic stress by lowering the BP, reducing the force of left ventricular contractions, and consequently the rate of rise of aortic pressure, retards the propagation of the dissection and aortic rupture. The treatment of choice for aortic dissection has classically been a vasodilatory agent such as sodium nitroprusside, phenyldopam, or nicardipine in combination with a beta blocker titrated to a heart rate of 55 to 65 beats per minute. Labetalol monotherapy has been used as an alternative. These drugs decrease BP, venous return, and cardiac contractility, thus decreasing shear stress to the aorta. One common regimen is a combination of IV sodium nitroprusside 0.5 to 2 micrograms per kilogram per minute plus IV esmolol. This combination can be used as initial therapy for KBS. The concurrent administration of a beta-blocking agent with a vasodilator is desirable because the latter may induce reflex tachycardia in response to vasodilation. Esmolol is a parenteral cardioselective beta-1 blocker with a rapid onset and short duration of action. For the management of hypertension, esmolol should be given as a loading dose of 250 to 500 micrograms per kilogram over 1 minute, followed by a maintenance infusion of 50 to 300 micrograms per kilogram per minute. Irritation, inflammation, and induration at the infusion site occur in 5% to 10% of patients. Hypotension is the most commonly reported adverse event and is directly related to the duration of esmolol administration. However, because of the short half-life, resolution of hypotension occurs within 30 minutes of discontinuing the infusion. Direct vasodilators such as hydralazine should be avoided because they increase stroke volume and left ventricular ejection rate. These effects augment the pulsatile flow and accentuate the sharpness of the pulse wave. This increases mechanical stress on the aortic wall and may lead to further dissection. Depending on the location of the dissection, surgical intervention may be required. However, until a definitive diagnosis is made, the primary goal is to reduce the BP and myocardial contractility to the lowest level compatible with the maintenance of adequate renal, cerebral, and cardiac perfusion. Aggressive BP control is warranted to minimize target organ damage and to prevent further dissection or hemorrhage. For aortic dissection, it is suggested that the systolic BP should be lowered to 100 to 120 mm of mercury or a mean arterial pressure of less than 80 mm of mercury within 5 to 10 minutes. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 317.